investigations in female infertility. We want to look at about four important things. One, you want to look at the patterns of the female genital tract, that is from the vagina, uterus, fallopian tube up to the ovary. Then you want to look at the reproductive hormone assay. Then you want to look at ovulation. Is this woman able to produce eggs? Then you want to look at their ovarian reserve. Ovarian reserve is how many of the antral follicles are still present, or how ovarian reserve, we are literally looking at how many follicles are available for this woman to be able to conceive. So let's look at the first one that is normally done wrongly, that is the reproductive hormone assay. Yes, I've said normally done wrongly because it is poor practice that a patient moves into your consultation room and then straight away you send them for reproductive hormones. We have seen our colleagues sending patients do follicle stimulating hormone, do luteinizing hormone just abruptly on the day they meet. So for reproductive hormone assay, we do them on specific days for the specific reasons that we know that from the time a woman starts seeing her menstrual flow, their reproductive hormone changes with the different days. There are different changes. So what are the reproductive hormones that we want to do in a woman? We want to look at follicle stimulating hormone, luteinizing hormone. You want to look at progesterone, you want to look at prolactin, you want to look at estradiol, that is E2, you want to look at AMH, you want to look at testosterone. But on what days do we do which hormone? Let's start with the baseline day that we are calling day 3. Day 3 in science, we are calling it the baseline day because that's the day when these hormones are at rest. Or should I say at rest? That's so much of a layman. But the hormones are still stable. So between day 2 to day 5, we do about 3 hormones. Which hormones are those? We do a follicle stimulating hormone, we do luteinizing hormone, and we do estradiol. That is day 3 follicle stimulating hormone. Day 3 is estradiol. Then we do luteinizing hormone, which is still day 3. I need us to note that at the start of the cycle, which we are calling baseline, these hormones are stable. So why are we doing follicle stimulating hormone, estradiol, and luteinizing hormones on day 3? That for follicle stimulating hormone, we know that the normal ranges, depending on the machines you're using, we would say between 1 to 11 international unit per liter. That is between day 2 to 5. That is specifically day 3. So why are we doing it? We want to see how much our bodies need to stimulate the ovaries to release to release an egg. That is the follicle stimulating hormone. That is the hormone that stimulates the follicle in our ovaries. So we want to know how much is needed. Therefore, what are we saying? We are saying if on this day 3 we find that we are having a very high follicle stimulating hormone, it means first of all we have a very low ovarian reserve. That's why our bodies will need a very high level of follicle stimulating hormone such that the ovaries can be stimulated. But then where we are seeing that we have a low follicle stimulating hormone, it means that these follicles are being stimulated even by little levels of follicle stimulating hormone. Therefore, we have a good ovarian reserve. But now we realize that we are doing estradiol also. At the same time, we do follicle stimulating hormone. Why are we doing that? Number one, estradiol, we use it to check if our follicle stimulating hormone test is accurate. That's why whenever we are doing follicle stimulating hormone, we want to do estradiol. That is one reason, to check that our follicle stimulating hormone level is accurate. That is on day 3. Though we have agreed that you can do between day 2 to day 4. That is day 2, day 3, day 4. Then what else are we saying? We are saying that this estradiol is important in the development of ovulatory follicles, endometrial growth, thickening and proliferation of the endometrial, that is to prepare the endometrium for reception of the fertilized product. So we are saying we want to check for the receptivity of the endometrium for implantation. Therefore, we are saying estradiol and follicle stimulating hormone are done hand in hand, and they check for ovarian reserve. So we are saying where they are high, it means you're having a low ovarian reserve. Yet where they are low, it means we are having a high ovarian reserve. Then we should also note that we are doing luteinizing hormone on this particular day. That is the baseline where the hormones are still stable, because as the days of the menstrual cycle goes, these hormones become unstable, they fluctuate. So we do also luteinizing hormone on day 3. We know that its main work here is to trigger ovulation. Therefore, we have a high surge of luteinizing hormone on the day that we have ovulation occurring. So that is one issue that is being mishandled. The follicle stimulating hormone, estradiol, and luteinizing hormone levels, we do them on day 3 when we are dealing with fertility. Then we go to day 21, progesterone. You've heard me saying day 21, that is the term we use. So progesterone, particularly in infertility, we want to do it on day 21. Why are we doing it on day 21? That after ovulation, the egg has been released. There's a product that remains, which we are calling corpus luteum, which has some cells in it. Its main work is to produce progesterone. And progesterone, we are saying, is primarily produced by corpus luteum after ovulation. And we should note that where there's a condition we call a luteal phase defect. In this defect, the corpus luteum fails to produce enough progesterone. Yes, corpus luteum fails to produce enough progesterone. So that is it. So the work of progesterone, we are saying that if it is high, it confirms that ovulation actually occurred. But then when it is low, it means that the cycle was anovulatory. There was no egg that was produced. I don't want to go so much deep into corpus luteum and then the follicle stimulating hormone production. I mean the day 21 progesterone, but that is a basic that is easily understood. So progesterone, you want to do it on day 21. That is for a woman whose menstrual cycle is 28 days. But for any other day, how you know it is you can subtract 7 from their number of days. If a woman is 35 days, is a 35-day woman, you want to remove 7 from 35. That becomes the day you do your progesterone. If she's 24 days, you want to remove 7 from that number of days. That is when you do progesterone. That's why we are calling this day 21 progesterone. That's for a woman whose menstrual cycle is regular, and particularly 28-day cycle. Because I need us to note that when we say a woman having regular menstrual cycle, we are meaning from 21 to 35 days. So it depends which woman you're dealing with, but what we need to know is you subtract 7 from the number of days. That's the day you want to check on your progesterone. Then the other hormones that we want to do, those are the particular days. Day 3, day 21. Then the other hormones we want to do, we want to look at prolactin, we want to look at testosterone, and we want to look at AMH, that is anti-Mullerian hormone. Maybe I start with anti-Mullerian hormone, the AMH. AMH, we should note that it is secreted by ovarian granulosa cells. That is of both the pre-antral and the antral follicles. Maybe that's a bit of science. Maybe in the layman's term, we should know that AMH is a hormone that is produced by the cells within the ovary. There are some cells within your ovaries. The cells that grow and hold the egg are the ones that produce AMH. What are we saying? We are saying when it is high, it means that you're having many eggs that are available for reproduction. And yet when it is low, it means you're having fewer eggs left for reproduction. Therefore, you're having a low ovarian reserve. High means you're having a high ovarian reserve. Maybe another thing we should note is testosterone. I think that thing is going to fall. Maybe you need to hold it. It may fall. That thing will fall. So the other thing is testosterone. Testosterone is a male hormone. We are aware about that. So what is its work now in female infertility? In female fertility, we are seeing that testosterone promotes development of follicles. Follicles are those things that we have said, they hold they hold the eggs, let it mature, and then release it. So they promote their development. So we are saying something that is funny with testosterone is that normally when you come to hospital seeking for fertility care, we tend to ignore the lower levels of testosterone. But maybe let's start from higher levels. When it is higher than normal, depending on the machines that you use, the parameters, the SI units may vary, but where it is higher, it will be associated with low fertility, because remember it's a male sex hormone. So when it is high, it is associated with either subfertility, low fertility, because we are saying where it is associated with the low fertility, such people are always even associated with blocked tubes. There's blocked fallopian tubes with them, at least that's so common with them with their infertility. Then we are saying that for women who are having high testosterone, they always have a bit or more of male sex characteristics. For example, facial hair, there's deep voice, some even develop obesity. That's the problem with the high testosterone levels. But now where it is low, these women always have sexual dysfunctions. For example, they be having decreased sexual desires. There's decreased sexual thought and fantasy. They also have difficulty reaching orgasm, or some even don't reach orgasm. So in general, I'm saying they have hypoactive sexual desire disorders. That's with the testosterone. So we see that all that is related to infertility in women. So you want to correct that. So you want to test that. Then prolactin, where it is low, normally the issues associated with it are not so serious. But maybe let's start where you find the prolactin levels are abnormally a bit high. Oh, we are saying it can stop ovulation, or it can slow it. Can either stop or slow ovulation, and it is normally associated with irregular menstrual cycles, or irregular menstrual periods, or even absent periods. The woman may fail to have her menstrual flow. Then we also see these women having menopausal syndromes. Menopausal syndromes can range from hot flashes, vaginal dryness, osteoporosis. That is prolactin. Then where it is very low, we see that these women, normally the obvious thing we know is that they will not be able to make enough breast for breastfeeding. But also, when it is very low, it causes delayed puberty, and it can also range also up to subfertility or even infertility. So these other hormones, we can test them on any other day. These prolactin, testosterone, and AMH, we can test them on any other day. But the rest, the luteinizing, follicle stimulating, and estradiol, then progesterone, we have seen that we do them on specific days. Then maybe something that we need to note is that, as we have already talked about the AMH and talked about the ovarian reserve, ovarian reserve is not only confirmed by AMH. Your doctor may also ask for an ultrasound scan to do an antifollicular count, but maybe that we shall look at it under imaging test. So that is reproductive hormonal assay. That is something that we normally mishandle. Then let's go to the next, ovulation. Your doctor has done reproductive hormonal test, but he also wants to confirm whether you are ovulating. We have seen one test you can do is day 21 progesterone for a regular woman with a regular menstrual cycle. But we also have the ovulatory testing kits, which you can easily get from pharmacies. It is now available even here in Uganda. It is available, only that lack of information makes us not know. But we have ovulatory testing kits that one can use. Therefore, how do we use it? If you go to your doctor and you tell them your menstrual cycle, your doctor will always be able to calculate and know the day he expects you to ovulate. Yeah, you will always know. But maybe for quick access, you can know the day you will ovulate. If you know the number of days of your cycle, you can subtract 14 from it. That is just something direct. If you're a 28-day person, you subtract 14, it comes to day 14. That is when you expect to ovulate. If you're a 24-day person, subtract 14, you will ovulate around the 10th day of your cycle. So what am I saying? That if your doctor suspects that you'll ovulate on a particular day, let me say day 14 for a 28-day person, your doctor will advise that for us not to miss, let us start doing this ovulatory testing. It uses urine as the sample. The same way you use the pregnancy test kits at home is the same way you use the ovulatory test kit. You just urinate, get a sample, and you dip it there. You wait for it to make the crosses, depending on which product you're using. Always have instructions. Therefore, you will want to start testing 7 days before the day you estimated, and then if it fails to react up to the day you estimated, you may continue for the next 7 days, such that you have at least a 14-day period of testing for ovulation. Once you fail to find it reactive, possibilities are that woman is not ovulating, or that cycle there was no ovulation. That is for the ovulatory testing kits. Then you can use the day 21 progesterone test. Though the day 21 progesterone test, we are saying that we are doing that test 7 days after ovulation has occurred. So maybe for a woman who is timing ovulation to conceive, you want to use the ovulatory testing kits, especially if your menstrual cycle is irregular. You can best know it when you use the ovulatory testing kits using urine. And we always advise you not to be so much under pressure. Be calm and let things go, such that you don't have hormonal changes. That is for ovulation. Then maybe the other thing that you want to check is the ovarian reserve. I've already explained to you what ovarian reserve is. So 2 ways we can check for ovarian reserve. Number one, you do a transvaginal ultrasound scan for antrofollicular count. Antrofollicles, they are actually visible using ultrasound scan. So your doctors or the sonographer can easily view it using a transvaginal ultrasound scan. How it is done is that they get the probe of the ultrasound scan and push it through your vagina, and then he's able to view both ovaries and is able to count the antrofollicles on both ovaries. Normally, we will do the calculation for the ovarian volume. He wants to see the sizes of the antrofollicles and then count their numbers. So, for the antrofollicles, it varies according to ages. For example, women in their mid-20s and 30s, we are saying that they can have as many as 12 to 30 antrofollicles that are visible on ultrasound scan. Then we have women who are now 30 to 40 years, they can have between 8 to 15 antrofollicles. Then we have women who are 41 to 46. Those ones can have between 4 to 10 antrofollicles. So when your antrofollicles are below 5, normally some say below 6. So when we are saying below 5, we are meaning 4 below or even less than 4. It means you're having very few follicles. You're having very low ovarian reserve. You have very few follicles that can mature to produce to release an egg. So your chances of reproduction also lowers. Though we are saying that the number of follicles doesn't necessarily give us your chances of conception, but again, we also say that the number of follicles give us how many eggs you have, how many follicles you have that can still mature to produce an egg for conception. Then maybe the last test is the checkup for uterine patterns or patterns of the whole genital tract. The first primary one we want to do is an ultrasound scan. An ultrasound scan can range from pelvic ultrasound scan to a transvaginal ultrasound scan. Though in fertility, we see that transvaginal ultrasound scan gives us a better view of both the uterus and the ovaries. So you want to do transvaginal ultrasound scan or a pelvic ultrasound scan. We are doing them to see for superficial abnormalities or diseases. For example, you can be able to view uterine fibroids. you're able to see polycystic ovaries, you're able to see endometriosis, endometritis, you're able to diagnose pelvic inflammatory diseases. Normally, we want to do ultrasound scan such that if we find something abnormal or infection, we can treat or correct. Then we have the second scan that we do, that is the HSG, which is hysterosalpingogram. That is more detailed, that it can give us more details for the blockages along our uterus and the tubes, because we realize that ultrasound scan is not able to tell us whether a patient is having a blocked tube or a blocked fallopian tube, but the HSG is able to. So how do we do the HSG? That your doctor is going to first of all do what we call a high vaginal swab, where a sample is taken from high into your vagina and then taken to the laboratory. They want to check for infections. You can do a wet preparation and give a quick result. But if for cases of chronic infections, you want to do a culture and sensitivity. So a high vaginal swab is taken, tested. If there is no sign of infection, then a dye is or a contrast is injected into the woman's uterus, where it will now spill to the two fallopian tubes up to the end of the ovaries. Then an X-ray is taken. That one will give us how the dye has spread. That's why we are saying it can tell us the pattern, whether there's a blockage where the dye may fail to enter or fail to spill. So that is what can give us a detail of your uterus. If there's a blockage, then your doctor will tell you. But we are testing such that since we are introducing a dye or we are injecting a dye into your uterus, we do not want to spread infections from your vagina or the cervix into the uterus and then the fallopian tubes themselves. So that is it. So those are the two scans, the ultrasound scan and the HSG, or the hysterosalpingogram. And these are not things from Mars. These are common tests that that we are using. Then the other obvious things, the obvious ones are screening for sexually transmitted diseases or the urinary tract infections, and then infections around your cervix. What am I saying? That your doctor may do a urinalysis test, your doctor may do a urine culture test, your doctor may check for syphilis, your doctor may check for HIV, then your doctor may do a cervical cancer screening. Your doctor may do a speculum examination to check for the nature of your cervix, the opening of your cervix. Those are the common ones. But when we are dealing with fertility, I think we have discussed wide the investigations we can do for infertility. At least the questions have been answered.